All right. Thank you, everyone, for joining us for this Fast Facts session on foodborne related illness. Got the feedback that we have a bland title. Hopefully that doesn't detract from this hot topic. I'm Hillary Spencer. I am the Infection Prevention Medical Advisor at IDPH, and my co-presenter is Shana. I'll let her introduce herself.
Hi, I'm Shana Altman. I'm the Foodborne and Enteric Disease Program Manager with IDPH Communicable Disease Section.
Thank you, Shana. We have a little bit of housekeeping before we get into the meat of the topic. This is our the CME accreditation statement for your review, if that applies to you. Obligatory financial disclosures, we have none. In terms of housekeeping, the webinar sessions are recorded and will be shared afterwards. Questions should be entered into the Q&A, which you can find there. I can't see it right now while I'm talking, but you can see on the screen that, and then there in the three dots, there's the links or the it pulls up the menu for the Q&A. And then a post-webinar survey is available for to attendees for 7 days after the session, and those who attend the webinar and complete the survey are eligible to receive a certificate of participation or continuing medical education credit as appropriate. All right, so on to the topic. I'm going to start with a brief history of food safety to provide context for the complex system that is our food control system today. And then I will hand it over to Shana, who will describe reporting requirements, enteric disease surveillance in Illinois, and outbreak response. This is a picture I took of the oldest report that I could find from the Chicago Board of Public Health, at that time, Chicago Board of Health. Earlier copies, as I understand, were probably lost in the fire. So this is from 1874 and 1875. I went looking for it when I was working on infant mortality at the Chicago Department of Public Health a few years back. And because my focus at that time was on infant mortality, I didn't take any notes about foodborne illness or food safety, but I remember seeing some reports about sanitation inspections, and that stood out to me as I was working on this presentation, that it's a historic topic and sort of thinking about our history and where that takes us. But back in the 1800s, it wasn't uncommon for people to consume milk containing formaldehyde, meat preserved with salicylic acid and borax, and coffee that was really filled with ground up bones and charred lead, not really coffee. I did find that there were rules for flour grading and inspection established in Illinois as far back as the 1850s, but in general at the time there were few regulations for food safety. And during my work on infant mortality, I came across this bit of history as well from the Infant Welfare Society. In 1908, the Chicago Milk Commission was formed to dispense safe milk in response to spiraling infant mortality that was reported to be resulting from a tainted milk supply. And that's sort of the history of the Infant Welfare Society as described by them in terms of their foundation. But you can see that food safety is highly related to other aspects of health and has a long history. And this sounds very familiar to concerns that we have today. So this is an article from 2023 about Chronobacter contaminating powdered infant formula, which led to illness in several babies. And sort of very timely, I pulled this example out, but during the time we've been preparing for this, we've had another very related instance come up. So I'll turn to that for just sort of a brief diversion and provide some information on that. But this is the recall of By Heart infant formula due to botulism infection. So I apologize that I didn't update this with the most recent case counts. This has grown from 15 cases, and all cases have been hospitalized. And this was as of a few days ago across at least 12 states, and that's been growing. We've had 2 cases in Illinois, and all of the cases have consumed By Heart infant formula prior to symptom onset. All lots at this point have been recalled, so all products, just for reference, there shouldn't be any product out there. Initially, there were only 2 lots that were recalled, and this was expanded on 11/11 to all lots. So it's important for folks to be aware of this and know to discard the product, or if possible to do in a safe way. Mark it, do not consume, store it away where it can't be used. And it can be stored in the event that an infant goes on to develop symptoms. It can take up to 30 days after consuming the contaminated product to develop symptoms. So if a baby consumed this product and then went on to develop symptoms, it may be helpful to have that product available. But most important is the safety in not re-exposing any infants to this formula. So just for a little reminder about what infant botulism is, symptoms include poor feeding, difficulty swallowing, decreased facial expression, loss of head control, generalized weakness. This can also be one of the early symptoms, can be constipation and as it says, as we talked about, poor feeding. But constipation happens in a lot of babies, but just something to be aware of, that it's also one of the early symptoms of infant botulism. Testing is done through serum and stool. The serum should be obtained prior to treatment, and stool is often, because these babies are constipated, needs to be tested after using an enema to obtain stool. And it's important to use non-bacteriostatic water so that the botulism itself isn't killed in the process of taking that enema. Testing is only done in consultation with public health. So this isn't something that you put an order in for and the lab sends it off. You do need to consult with public health, but just to have some awareness of what testing methods are used. And then I think it's just another highlight that it takes, these results can take quite a while. So it takes at least 10 to 14 days. Sometimes it can take longer. It's a multi-stage testing and requires the use of live mice to get final results on this too. So it takes a long time. It's a lot different than many other tests that we do. Treatment is with Baby Big. This also is something you can't just put an order in for. It comes from and is approved through the public health system, and with the California Department of Public Health runs the program for infant botulism. So if you suspect botulism and need to test or treat, it's really important to call your health department to get that in order. And just a little side note that once infants have received Baby Big, and because a lot of these, these are young infants who may not have had live virus vaccines and maybe due for live virus vaccines in the near period, they should be deferred for 6 months after receipt of Baby Big. And then supportive care. These infants need a lot of supportive care in the hospital setting as they overcome this illness. So that's just a little note about infant botulism and the product contamination, which has been in the news recently. But modern food safety concerns aren't limited to formula, even though these last couple of examples were about formula. It seems like every other week there's a food recall that's in the news, and these are just a few examples just to highlight the kinds of things that we see. We've recently, seen this listeria in prepared pasta meals. That's been, all over the news, and people have been paying attention to that. But there are, many recalls that we hear about for various different things. And Illinois and Chicago in particular have a pivotal role to play in the history of U.S. food safety. The Jungle, which was published in 1905, was set in the meatpacking plants of the Chicago stockyards. Upton Sinclair's depictions of the dangerous working conditions and unsanitary practices and food adulteration drew national attention to the unsafe food production practices. And as a result of the Jungle, the first national food safety law, the Meat Inspection Act, was passed in 1906. The Meat Inspection Act set sanitary standards for meat processing and interstate meat shipments and prohibited companies from mislabeling or adulterating their products. Also in 1906, the Pure Food and Drug Act created the U.S. Food and Drug Administration and prohibited the manufacture or sale of misbranded or adulterated food, medicines, and liquor in interstate commerce. So all of this is to say that the prevention and mitigation of foodborne illness has a long history and is a core function of the public health system. Excuse me. Farm to table is something we hear a lot about. It's a social movement promoting locally grown food. But rarely, if ever, is food production so straightforward as from farm to table. There are typically many steps along the way, which introduces many challenges to food control. So from farm to storage, packaging, and processing, distribution, and sometimes, this can be across state lines and across national borders as well. Preparation, which can be, at home or commercial production to the table. And I think, there are also things to consider about post-table with things like in your own home with like leftovers and that kind of thing. Maybe not part of the food control system, but something to be aware of in terms of food safety. Here's a schematic of a national food control system. Food control and safety is not just one activity. It includes laws and regulations, food control management, inspection services, food monitoring, and epidemiological data and communication, information, education, and training. I dare say we're participating in food control right now through education, one aspect. Food control also doesn't just happen at just one governmental agency or even one level of government. There are laws, regulations, and guidance, which with enforcement mechanisms at the federal level, but state and local jurisdictions incorporate or build off of the federal food code within their jurisdictions. While states have much in common, there are differences from state to state, such as whether raw milk is permitted and regulated, as one example. I'm going to go over a brief review of the different agencies which contribute to food control and how they complement each other in food control. And this to make the US one of the highest in the world for food quality and safety. According to the Global Food Security Index, the US ranks behind only Canada and Denmark for food quality and safety. This is a fact that is often lost in the current rhetoric about food safety. But while we celebrate this win, we can't rest on our laurels. Efforts to deregulate and defund critical infrastructure threaten to systematically erode food safety. All right, a little bit about the U.S. Department of Agriculture, or USDA. The USDA has many different programs to support farms and farmers and to promote sustainability and food security or access to food through programs like WIC and SNAP. It is their Food Safety and Inspection Service, or FSIS, that complements the food safety and food control system. FSIS enhances public health and well-being by protecting the public from foodborne illness and ensuring that the nation's meat, poultry, and egg products are safe, wholesome, and correctly packaged. This really sort of echoes back to the initial meat inspection and what we learned about from the jungle. So the USDA focuses, in terms of their part of food safety, focuses on meat, poultry, and egg products. Another sounds in some ways similar to USDA. We've got the FDA, or the US Food and Drug Administration. It has food in its name, but it's only one part of what the FDA does. And this is a snapshot of their org chart, and you can see highlighted here or circled here is the Human Foods Program. And this is where the food safety work for the FDA is housed. The Human Foods Program is made up of a couple of different offices and the programs within those. And I just share their org chart here to give you an idea of the work they do. They have the Office of Food Chemical Safety, Dietary Supplements, and Innovation. They do pre-marketing, additive safety, post-market assessment, and their dietary supplement programs. And you can see some of the different divisions that they have within there. And then also the Office of Microbiological Food Safety, which focuses on dairy and seafood safety and produce safety. And this is just a diagram that I found because they sound sort of similar. FDA, USDA, a lot of the work they do sort of sounds similar, but to highlight sort of the different activities that these agencies do and how they complement each other. So the FDA regulates about 80% of the food supply, and including packaged foods, dairy, seafood, processed produce, etc., while the USDA focuses on meat and poultry products and egg products. And then at the state level, there are activities and functions that the Department of Public Health have for food safety and protection, as well as the Department of Agriculture, sort of mimicking what happens at the federal level. The Department of Agriculture regulates shell eggs, meat, poultry, meat and poultry products such as meat lovers pizza and catfish. At the Department of Public Health, within the Division of Environmental Health, there are programs for food protection and the dairy program. The Food Protection Program oversees retail food production, manufactured food production, bottled water, and salvage. And some of these activities are done in conjunction with the FDA and as delegate activities, and some are separate from that and are state functions. Activities include inspection of manufactured food firms, establishing state minimum standards for food safety, technical assistance and training for public health partners in food industry, environmental assessments, sampling, and traceback during foodborne illness response, and public education about food safety topics. And then the dairy program inspects dairy from farm through distribution. This is a diagram that shows sort of a flow chart to determining retail versus wholesale and regulating agency. And I'm not going to go through all of the details of this, but to highlight sort of the complexity and a resource that exists to determine this, sort of where to go about food safety, what regulations apply, and at what levels those apply. And then local health departments. So local health departments are the regulatory authority for retail food establishments in Illinois. And the minimum standard is the Illinois Food Code and FDA Food Code as adopted. Activities include permitting, licensing, and licensing food establishments. And this includes many different kinds of food establishments. I didn't realize until I came to work at the health department, sort of all the different kinds of food establishments that exist and that the health department and local health departments regulate. So this includes restaurants most commonly, but grocery stores and particularly grocery store kitchens. This includes school kitchens, hospital and kitchens, daycare centers, long-term care, all of these different places where food is served. And activities focus around compliance and enforcement, community education, and leading foodborne illness response in food establishments. So this is just an example. Every health department has different variations. I highlighted this one as I traveled to Seattle recently, and then I'm not picking a specific local health department to sort of highlight. But I thought this one was sort of interesting, and you can see in food establishments, locally to what the rating is, but this was an example of one that was like really obvious as we were walking around and colorful and sort of stuck with me. All right, so even though we have one of the safest food systems in the world, people still get sick. So if something slipped through the cracks and you get sick, now what? Shana will give you more details on surveillance at the state level and what IDPH does to detect and respond to foodborne illness, but I want to give a brief overview of surveillance that happens at the federal level that complements some of the surveillance that we do at the state and local level to give you a sense of how complex this is. So FoodNet is a collaboration among CDC, the U.S. Department of Agriculture, the U.S. Food and Drug Administration, and 10 health departments. It's an active surveillance network and population-based. This means they do more complete surveillance data and gather additional information on cases, and it covers about 16% of the U.S. population to provide a representative data on foodborne illness surveillance. Historically, FoodNet focused on the 8 organisms listed here, but recently this has been in the news for scaling back. The CDC, this headline says the CDC quietly scaled back a surveillance program for foodborne illness. And this got a lot of attention, and one of the reasons why I wanted to highlight this here, because what I heard is we don't have foodborne illness surveillance anymore. This is being scaled back by the CDC, that this program is being scaled back, and this has been as an absent activity of public health. And so now the program focuses on more narrowly on Salmonella and STEC. But I wanted to highlight this because this is not the only program that does surveillance. And while it is tragic to lose this enhanced surveillance. There are still many other aspects of foodborne illness surveillance that are done, as Shana will highlight what we still do at the public health department, and sort of recognizing that this is complex and there are many aspects of foodborne illness surveillance that continue to happen even as this one program was scaled back. These are a couple of other programs. PulseNet, this is a national laboratory network that connects foodborne, waterborne, and One Health-related illness causes to detect outbreaks using whole genome sequencing. And there's a lab in every state, including in IDPH. This is one that IDPH in Illinois participates in. Food Corps is another program in which 10 state and local health departments collaborate to improve methods to detect, investigate, respond to, and control multi-state outbreaks of foodborne illness. And you can see here the map of those states that are represented there. And then we also have the Integrated Food Safety Centers of Excellence. These were established in 2012 under the Food Safety Modernization Act. Partnerships between state health departments and academic institutions to identify and implement best practices serve as peer resource for public health professionals. So you can see while there are only a handful of these centers of excellence, they are networks in which our state and health department is included, and these serve as a resource to us here in Illinois as well. All right, now I'm going to go over a brief overview of diagnosing foodborne illness. And these are several steps that have been laid out when diagnosing foodborne illness, starting with suspecting, identifying, treating, and then reporting. So in terms of suspecting foodborne illness, many foodborne illnesses start with, and we sort of think about foodborne illness as being diarrheal illness, can include abdominal pain, fever, vomiting, and bloody stool as well. I say that this is usually like to highlight that there are also sort of the last bullet point on here too. There are other non-infectious foodborne illnesses, and there are different presentations to some other non-diarrheal pathogens, for example, botulism. But when we think about foodborne illness, we often think about these diarrheal illnesses. So individuals at increased risk may have more severe or atypical presentations. These include children under 5 and adults over 65, pregnant people, immunocompromised, people with immunocompromise and other underlying conditions. Foodborne bacteria may cause more illness and different manifestations than we typically realize. So this is also here, this picture is a snapshot from a report which highlighted that nearly 1 in 5 urinary tract infections were tied to E. coli that is found in meat. So in this study, 18% of E. coli causing UTI came from food animals. I think it's just interesting because we don't commonly think about urinary tract infections as being a foodborne illness, and they may not be the sort of the classic presentation, but food control and safety is so important for so many different aspects of health and illness, and there may be sort of presentations related to foodborne pathogens than we have typically realized. So as I mentioned, there are other non-diarrheal pathogens. One example is botulism, and there are also non-infectious foodborne illnesses. So in the last few years, we had contaminated applesauce that was contaminated but with lead. And then one that came up that I thought was really interesting was nightshade in spinach, and it has caused anticholinergic symptoms in folks who are exposed. So in terms of suspecting, there are a lot of different kinds of foods and, different problems that can sort of lead to what are risky foods or to lead to foodborne illness. But in terms of sort of red flags, thinking about particularly risky foods include unpasteurized dairy, raw or uncooked meat. Also really important to think about risky foods that people may be aware of in the news. So these could come from recalls. And there's a link here to the site where you can find recalls. As well as I encourage you to sign up for a siren if you haven't already. Many of you probably are familiar with siren since the advertisement for this webinar comes out through siren, but if it was forwarded by a friend, I highly encourage you to sign up for siren, which is the state's health alert network. Other red flags for foodborne illness include recent contact with animals, recent contact with sick friends or family, travel abroad or exposure to a body of water, or recently eaten at a restaurant or event with groups of people, served common foods, especially if other people are known to be ill. As I mentioned, there are other kinds of foods than these like high-risk foods, unpasteurized dairy and raw or undercooked meats. And as a vegetarian, I kind of thought that I was at sort of lower risk, but was at a conference where I joined a session on foodborne illnesses and heard about things that I had never sort of recognized as particularly risky, like peanut butter, cashews, heard a case about people who didn't eat meat but ate off food that was cooked on a grill where bear meat that was infected with trichinella was prepared. So there are many different ways that we can be exposed, and sort of no one is immune from potentially being exposed to foodborne illness. That next step, so suspect first and then identify, we identify through testing. There may be more cases in which you choose to or want to obtain testing, but there are some circumstances where it's more important, maybe more important than others, for either patients or for public health reasons. So more severe presentations, those including fever, bloody or mucoid stools, severe abdominal pain, and signs of sepsis are indications for treatment in individuals who are immunocompromised, because there may be different implications of foodborne illness for people who are immunocompromised, people who are exposed to an outbreak or known to have eaten food that was part of an outbreak exposure. And then I think from the public health perspective, this isn't always appreciated on the clinical side. We sort of see patients in isolation in the clinical setting, but there are implications that that individuals may have, for public health. So work or social history that has public health implications. So particularly for individuals who work or attend daycare, or who work or reside in a long-term care setting, healthcare workers, and food service workers are some of the implications. So these are people who, if they are ill, they're in a congregate setting or a risky, an occupation, a sensitive occupation, in which identifying the specific organism can be very important for the public health response. So these are people who may not have the most severe presentations, but because of their work or aspects of their social history, it's even more important to identify the source of infection. So in terms of identifying, again, it depends on what kind of foodborne illness is suspected, but as we're thinking about diarrheal illness, one topic that comes up is culture-independent diagnostics, or CIDT, which are commonly, frequently PCR-based methods versus culture. So there are several different factors that have to be considered in terms of which you're choosing. One is what the lab is offering. Some labs have moved away from offering culture based methods for stool testing of bacterial pathogens. And certainly PCR labs have become more widely available as well. So just what you have available may be a factor. PCR tests may identify multiple pathogens. This can make it more difficult to interpret as well. So sometimes you come up with pathogens of uncertain significance. I see this as in pediatrics, I see this not uncommonly, that you test and find 3 or 4 different pathogens, just like we do for respiratory illness. And sometimes it can be difficult to determine which of those is causing the current presentation of the illness. So it leads to some uncertainty. Culture can be more specific, but it can also be less timely. And culture can also be beneficial because it's available for, the isolate is available for whole genome sequencing, which can aid public health investigations. So just some factors to consider when you're deciding what tests to pursue. And in that, the next step is treatment. I'm not going to go over like all the different forms of treatment, but I want to highlight here the IDSA guideline for management of infectious diarrhea as a resource. And then that last step is report. So now I'm going to hand it over to Shana. As introduced, Shana is the Foodborne and Enteric Disease Program Manager at IDPH, and she's going to take you through reporting, surveillance, and outbreak response.
Great. Thank you, Dr. Spencer. Good afternoon, everyone. So I'm going to start and just briefly talk about the different possible etiological agents that are associated with foodborne illness. CDC does estimate that each year there are roughly 1 in 6 Americans, or approximately 48 million people, that get sick with a foodborne disease. And of those, there are 128,000 people that are hospitalized and 3,000 that die. As you can see from my slide, there are a variety of agents that can cause foodborne illnesses, and this includes different bacteria, viruses, parasites, and even some chemicals. Looking at this slide, I have included the different types of etiological agents, but not all of these are ones that are reportable in accordance with the Illinois Notifiable Disease Code. The pathogens that are considered to be reportable in Illinois are those that have an asterisk next to their names on this slide. So those reportable pathogens do include Campylobacter, botulism, Shiga-toxin-producing E. coli, Listeria, Salmonella, which does include both typhoidal and non-typhoidal Salmonella, Shigella, Vibriosis, Hepatitis A, Cryptosporidium, and also Cyclospora. And so even though all foodborne illnesses might not be reportable in Illinois, all foodborne outbreaks are reportable to the local health department and then also to IDPH within 24 hours. Next slide, please. So mandated reporters must report suspected or confirmed cases of certain diseases to local health departments within a certain number of hours or days, and this all depends on the disease. So reports of reportable infectious diseases should be submitted electronically through our Illinois National Electronic Disease Surveillance System, and this is in accordance with the Illinois National Notifiable Disease Code. The IDPH public website has a page that provides an overview of the infectious disease reporting requirements here in Illinois. And within this page, you will find the persons that are required to report those diseases. This does include physicians, nurses, healthcare practitioners, just to name a few examples, but the list is very extensive. In addition, on this page, you'll also find the diseases that are required to be reported immediately by telephone, while the remainder of the diseases should be reported electronically through INEDs. Also, within the code, you will find additional information for each of the reportable diseases and the time frame from which they are to be reported, as well as how they are to be reported. There are some publication resources that are available out on the IDPH infectious disease reporting page. One of those is an example on this slide is that Stop Report Infectious Disease poster. If you don't have a copy of this poster handy, I do recommend that you visit the IDPH website and print a copy so that way you have it available. The poster just provides a quick glance at the reportable diseases in Illinois, and it also identifies the timelines for which they are reportable. There's also a separate poster that goes with this one that includes the requirements for laboratory reporting and what specimens are to be required or should be forwarded to the state lab in accordance with the code. Next slide. This slide provides an example from the Illinois Notifiable Disease Code for a foodborne disease. So the one that is included on this slide is for Salmonella. Within this disease-specific section in the code, you'll find the requirements for the control of the case, as well as any context of the case, which may include restriction or release specimen requirements for certain occupations. In addition, you also find that there's a lab reporting requirements section, and this provides the information regarding the lab tests that are required to be reported. One component of reporting that we often receive questions about is related to the specimen source. So for many of the enteric diseases, a positive is required to be reported regardless of that specimen source that it was obtained from. So for example, Salmonella. Laboratories, the code indicates that laboratories shall report to the local health authority patients from whom Salmonella has been isolated or patients who have a positive result on any other lab test indicative of and specific for detecting Salmonella infection. Since the code doesn't indicate that only a certain type of specimen should be forwarded to the state lab, any clinical specimens that are positive for Salmonella should be reported and then sent to the IDPH lab, regardless of the specimen source. So this could include specimens that were positive by stool, it could include urine, blood, or even wounds. Next slide, please. So how does reporting work here in Illinois? All reportable infectious diseases are required to be reported into the Illinois National Electronic Disease Surveillance System, with the exception of HIV and AIDS. Surveillance begins with the reporting of those diseases, and it occurs lots of different ways here in Illinois. Many cases now are sent by electronic lab reporting, which is also known as ELR. And so this happens whenever a laboratory sends a secure file and they have a standard messaging format that then gets imported into INEDS, and it's mapped to the appropriate disease. It's important for providers to know if their laboratories are using the electronic lab reporting to be reporting these reportable results. And then local health departments should also review and process those electronic lab reports once they receive them in INEDS. The INEDS provider reporting module is also an option for reporting. It includes a paperless reporting system for healthcare providers. And so cases can actually be entered directly into INEDS by providers and routed the same way as those ELR reports are to the jurisdictions. So when providers are reporting, it's important to include as much information as you can, making sure that you're including demographics, the lab testing, hospitalization status, just to name a few examples. And then finally, we do still receive some reports that are coming through mail or fax and things like that. And so when we receive those, they are then also manually entered into INEDS. So that way we're ensuring that all reportable diseases are entered into our disease surveillance system. And then once those reports are entered into the disease surveillance system, they are then routed to the jurisdiction where the case resides. So that way the local health department can follow up with them to conduct interviews and obtain additional information regarding their illness. And then once the local health department obtains all the information on that case, they'll send it to IDPH to review, and then we also transmit this data to CDC. Next slide, please. Next, I'm just going to talk briefly about diagnostic testing. Dr. Spencer already did a great job covering the different types of diagnostic testing that can be done. I think one thing that is important to note is just that it's important to conduct testing. We know that oftentimes that people have less severe illness, they might not be tested, and they're often just sent home indicating that they have had some kind of gastrointestinal illness or foodborne illness. And so many foodborne illnesses do go undiagnosed, and so CDC does estimate that for every 29 salmonella illnesses that occur, that there is one that is laboratory confirmed. So I just wanted to note that as well. And then as we are continuing to see that many labs do testing via CIDTs, and so we always want to continue to encourage laboratories to still conduct culture testing on those specimens. So if there's a CIDT and a positive result is obtained, we encourage labs to still conduct cultures on those specimens, so that way an isolate can be sent to the state lab. But even if cultures aren't performed, laboratories are still required to send those positive specimens to IDPH lab in appropriate media. And it's really important to ensure that laboratories are familiar with the requirements of how specimens should be sent and the time frame for when they should be sent, so that way they can be tested once they are received at IDPH lab. And then isolates that are submitted to IDPH lab, as well as those clinical specimens that are confirmed via culture, they are submitted for whole genome sequencing, which we also will refer to as WGS, which assists with the identification of outbreaks, which I'll talk a little bit more about soon. Next slide. Another component with the importance of understanding diagnostic testing is just that making sure that you understand the results for the reports that you're receiving. And so there are lots of different types of GI panels, and different laboratories report results differently. Well, many lab results are received electronically in INEDS from laboratories, not all are. So it's really important just to ensure that you understand the results that you're receiving. We oftentimes do see some confusion between results for Shigella and E. coli. There's lots of different types of E. coli, and some of them are reportable while others are not. So EPEC and ETEC are not reportable as E. coli's, and if a specimen tested positive for just EIEC, if a specimen positive for Shigella/EIEC, that is reportable as Shigella rather than as an E. coli, and so that often causes confusion too. So it's just important to ensure that that whenever you are receiving lab results, that you understand the results that you're receiving. Next slide, please. So why do we conduct enteric disease surveillance here in Illinois? There are lots of different reasons, but verifying the patient's diagnosis and education on the disease and how it's transmitted can be provided to the patient by the provider and the local health department, and that helps prevent the spread of further illness to other people. And then when a reportable foodborne illness or an outbreak is identified, interviews are conducted by the local health department. They obtain information on different types of exposures. So what foods did they consume? Where did they go out to eat? Like Dr. Spencer had mentioned, do they have any contact with animals? Do they have any contact with water? Those types of things. And investigations help us pinpoint how the illness is spreading. Is that illness being spread through person-to-person transmission, from people coming in contact with each other? Is it from a contaminated food or contaminated water source, or even environmental factors? And just knowing that source helps guide appropriate control measures. Once a food item has been identified that's being suspected to cause illnesses, additional actions can be taken, such as inspecting restaurants or facilities, or potentially even the removal of a food item by a recall to prevent additional people from becoming sick. And then by investigating outbreaks, public health agencies can also better understand what caused that outbreak and how can we prevent similar outbreaks from happening in the future. In addition to helping control the outbreak and reduce the number of ill people, outbreak investigations also provide us with valuable data. It helps us better understand the diseases and preventing outbreaks. Investigating outbreaks also just gives us an opportunity to assess the effectiveness of the existing practices that we have, and so that we can identify areas of improvement, such as updating our guidelines for future outbreak response. Next slide. So disease surveillance. Local health departments and IDPH both conduct disease surveillance in several different ways, and we do this to help us identify a potential cluster of illnesses. And providers can be a really helpful tool in the early detection of foodborne illness outbreaks too. So there are many ways that providers can assist, and these can include notifying your local health department if a patient reports that a food item they believe made them ill. Also, a provider might identify maybe you're seeing more people that are coming in and they have GI illness than what you typically expect. And so that might be a reason to just notify your local health department and make them aware. A patient might make you aware that they dined with other people at a restaurant and then they subsequently became ill, or maybe they attended a common event where they know other people that became ill. Or if you work in a long-term care facility and you identify that there are multiple people within your facility with GI illness. So all of these are important details to share with your local health department whenever you do receive that kind of information. Another example of disease surveillance is foodborne illness complaint systems. Local health departments receive foodborne complaints from the general public, and this will trigger the local health department to conduct an investigation into those illnesses. The local health department may also be conducting disease surveillance. They could be looking at and see if they have an increase in the number of foodborne illnesses that are being reported. This could be specific to a disease, or they could identify multiple cases that have the same exposure, including residing in the same facility as well. And so also at the IDPH communicable disease section, we also monitor daily surveillance reports, which I'm going to share a few examples with you shortly. And then also, Hillary touched on this briefly, but also CDC does conduct disease surveillance and monitors for clusters of cases across multiple states that are related by lab testing, and this is conducted by whole genome sequencing and through PulseNet. Next slide, please. I wanted to provide some examples with you of ways that providers have reported information into INEDS previously that have helped with the identification of outbreaks. And so when providers enter reports into INEDS, they can also include information on the known symptoms and assist the local health department with identifying if there could be something that might need to be prioritized for interview. So this slide just includes some examples of reports that have been received previously through electronic provider reporting. So an example would be that the top left is an example of the ground meat. We had an outbreak associated with ground beef at one point in time, and this was a few years ago now. And so in this investigation, we received several reports from providers about cases that were making complaints about suspecting that their illness was associated with ground beef. We don't see that occur very often, and so we thought it was very interesting in this investigation as we'd received multiple complaints or reports like that of people that had associated their illness with their ground beef. And then also, if somebody might report travel to Mexico, this can be really important to know, especially with cases of cyclospora. We're typically looking for, we know cyclospora can be acquired outside of the United States, and we're looking for clusters within the United States, and this really helps guide the local health department with their interviews. Also, if you receive, the other one on the top right shows an example of a Mexican restaurant where there were multiple people that had gone out and become sick with similar symptoms. Down towards the bottom on the left, the patient states she works in a restaurant and multiple employees have the same symptoms. This is really important to know because, one, could there have been something that happened at the restaurant that could have made other people outside in the community sick? And then also, follow-up needs to occur with those employees to ensure they aren't working, especially if it's a disease that requires restrictions and release specimens. And then we also have some diseases that have requirements for release specimens for children that attend daycare. And so including that information in initial reports is also really helpful. So that way the local health department can follow up with that case promptly, or the parents of the case to get additional information, ensure they aren't attending daycare while ill, but also following up with the daycare to see if there's other reports of illness. Next slide, please. And so, there are a couple different types of outbreaks and how we report them into the Illinois outbreak reporting system. And so I just kind of wanted to tell you about what kind of outbreaks that we do have and the number that have been reported. And so the number of reported foodborne outbreaks that include cases from Illinois between 2020 and 2024, the 5-year median for those was about 50 outbreaks per year. And on this slide, it does break down those outbreaks into 2 separate categories, and that's counted by Illinois and CDC, which are typically outbreaks where the majority, if not all of those cases are from Illinois and they're investigated locally. And so this is during the same time frame between 2020 and 2024, there were 145 outbreaks that were reported that were investigated locally and not included in multi-state investigations. And then the other category is counted by Illinois, and these are outbreaks where Illinois cases are included in the multi-state investigation, where CDC is reporting it to their national outbreak reporting system. And we don't want to duplicate those efforts, but we also want to ensure we're capturing the details of the response so that way we have it and we can improve in response in the future. And so between 2020 and 2024, there were 97 foodborne outbreaks reported to the Illinois outbreak reporting system that were part of a multi-state investigation. Next slide, please. Now I want to highlight just a few of the reportable enteric diseases and the requirements that are related to restrictions. So for salmonella, case counts range from 1,340 in 2020 to 2,187 in 2024, with a 5-year median of 1,835 cases a year. Typically during the warmer months, we see an increase in the number of people that are being diagnosed with salmonella. When there is a salmonella case that's identified, there are requirements for restrictions and release specimens for specific occupations. And so I just wanted to go over those with you today. So a food handler is defined as anyone who has the potential to transmit foodborne pathogens to others from working with unpackaged food and equipment, clean utensils, oral medications, or food contact services, and any person who has the potential to transmit foodborne pathogens to others by directly preparing or handling food, drinks, or even preparing oral medications or oral care. So food handlers, food handler does not include those individuals that are working or that are in their private homes and are serving foods for their individual families. There wouldn't be restrictions for that. If a case of salmonella is identified that indicates they work in an occupation that meets the definition of a food handler, the local health department will restrict that person from food handling duties until 2 negative specimens are obtained. In addition, there are same requirements for those that are working in a sensitive occupation that are identified to be a case of salmonella. A sensitive occupation is defined as an occupation excluding healthcare workers involving the direct care of others, especially young children and the elderly, or any other occupations designated by the department or the local health authority, including but not limited to child care facility personnel. So if a case of salmonella is identified in a person who works as a healthcare worker, the health department may require release specimens. For healthcare worker, the requirements may vary by the local health department and depending on the job duties that they're performing. If there is a patient who tests positive for salmonella who attends daycare, there are no requirements for release specimens. However, the child shall not return to daycare until fever-free and diarrhea and vomiting-free for 24 hours without the use of medications. Next slide, please. Next, I want to talk about Shiga toxin producing E. coli. So when we look at case counts for STEC, case counts range from 357 to 657, or 651, with a median of 493 cases. So from looking at when cases became ill, you can see that for STEC, we also see an increase in the summer months, but the increase happens a little earlier than it did for salmonella. The requirements for STEC and release specimens for STEC are similar to those of salmonella, with the exception of daycare attendees. So if a person is positive for Shiga toxin producing E. coli and the child is under the age of 5, or they're incontinent of stool, then they shall be restricted until 2 consecutive negative specimens are obtained, and then they can return to daycare. Next slide, please. Next is Shigella. The median number of cases reported for Shigella is 487, which is similar to STEC. There were requirements for restrictions and release specimens for Shigella are the same as salmonella. With those that are food handlers or work as food handlers or healthcare workers or in sensitive occupations, they may require release specimens. If a case is identified in a daycare attendee, the child shall be excluded from daycare until that 24 hours of symptom-free. Next slide, please. This slide just covers the general procedure for the control of communicable diseases, and this is identified in 690.30 of the IDPH notifiable disease code. So persons who are suspected of being infected with a notifiable infectious disease for which isolation is required, or persons with diarrhea or vomiting believed to be infectious in nature shall be refused admittance to the school or child care facility until they are fever-free, diarrhea-free, and vomiting-free for 24 hours without the use of any medications. And then if for persons that have diarrhea or vomiting of infectious disease that may work as food handlers or those in sensitive occupations, they should not return until their symptoms are resolved for 48 hours. Release specimens aren't required for norovirus, but food workers are excluded from working in food handling duties until that 48-hour rule of being symptom-free until those symptoms have resolved for 48 hours. Next slide, please. So how can providers help with exclusions of release specimens? And there's lots of different ways. So when the disease is reported to the local health department, if you know the person works in an occupation that may require restrictions in a release specimens, include that in your notification to the local health department so that they can be made aware promptly. Next, when the patient's notified of a positive lab result, you can also let them know that the health department will be calling them as their occupation may require restrictions in a release specimens. This helps ensure that the patient is aware that they shouldn't be returning to work, and also helps build the trust between the local health department and the case, as they know that their healthcare provider works with and partners with public health as well. Release specimens can be collected for testing through providers or through the local health department. If a provider is assisting with collecting specimens for testing, it's important to communicate this information to the local health department, ensuring specimens are collected in accordance with the code, and then sharing those results with the health department so that the patient can be released back to work as quickly as possible. And last but not least, it's important to understand that restrictions and release specimens are collected based off of the initial testing that was conducted. For example, we often see that a person may test positive for STEC on a GI panel. That specimen is sent to our state lab for culture confirmation, and the state's unable to detect Shiga toxins or isolate STEC. Even if that specimen isn't confirmed by a culture, the person is still restricted based off of that initial test result. There are many different reasons that a specimen can be positive at a clinical lab and then unable to confirm at the state lab. Well, it could have been a false positive. It also could be related to a low pathogen load, poor specimen viability, among other reasons as well. Next slide, please. And then just real quickly, because I'm at my time, you may recall hearing about a listeria outbreak that included recalls associated with supplemental shakes earlier this year. Upon investigation closure, this outbreak did include 42 cases from 21 states, with 5 cases of those being from Illinois. So I just wanted to highlight some of the actions that were conducted for this investigation. This outbreak was originally identified in December 2018 and investigated again in 2021 as well as in 2023. And then in October 24, there were 6 additional illnesses that were reported, which prompted CDC to reopen the investigation and to investigate it further. Most people in the outbreak resided in long-term care facilities or were hospitalized prior to the illness onset, indicating that a food that was served in those settings was the likely source of the outbreak. When the investigation was reopened in 2024, state and local health departments worked with healthcare facilities. They helped with collecting menus, invoices, obtaining medical records, and even foods for sampling. FDA and CDC identified that the frozen supplemental shakes was a common food item across the invoices from the facility where the ill people were staying. So comparison of those item numbers and the production facilities found that the two brands on those invoices were made by a common manufacturing facility. FDA conducted inspections as well as collected product samples and environmental samples for testing, and due to all of the information that was gathered in this investigation from epi, laboratory, and environmental evidence, there were recalls for Lions, Ready Care, and Cisco Imperial frozen supplemental shakes in February. Next slide, please. The ultimate goal of foodborne illness investigations is really to prevent further illness and protect the health of the public. So achieving this goal is never the work of a single individual. It takes a coordinated effort from an entire team with different areas of expertise, from healthcare providers to our local and state health departments to federal agencies, and those within the food supply chain, like Hillary mentioned earlier. Each partner plays a vital role. So it's important to note that these investigations can begin with one keen eye and timely action of a healthcare provider. As I like to say often, teamwork makes the dream work, and nowhere is that more true than protecting our communities from foodborne illnesses and foodborne diseases. Next slide. And then I will turn it back over to Hillary.
Thank you, Shana. This is just one slide to share another resource that you may be interested in. It's a webinar that was put on by the Doctors for America on food policy and public trust, a clinician's role in advancing food safety, if we've whet your appetite for more about this. And then we're running towards the end of time. This would be the time for questions that I recognize we're almost at 1. I don't see any unanswered content questions in the Q&A, but if you all have questions, as we're coming to the end of time, we'll try to get those back to you, or if you have questions to send after the fact, you can do that as well. And just to wrap up, the next to come in the PHACT series on December 18th, we will have a webinar on moving forward by looking back, a roundup of major public health events and responses over the past year. And you will have the link to register for that, as well as that will come by Siren as well. You can reach out to us here via this QR code or the link for questions related to this presentation or other questions that you have for the medical services team at IDPH, or if you have suggestions for future topics, feel free to send those there. And then another reminder, we remind every time is to sign up for Siren. This is the state health department's health alert network, and this is how we reach out to clinicians to notify you of outbreaks of significance and other health alert information in the state. And then lastly, up to 1 hour, 1 credit hour of CME is available for those wishing to obtain CME credit. Complete the evaluation survey and quiz at the end of this webinar utilizing the following link, which will also be sent to you on or before December 2nd. And I see that maybe there's another question that has come in, but recognizing that we're at time, we will we'll grab that question and get back to you all. And thank you all so much for joining. And I hope that you have a Thanksgiving celebration that is healthy and safe. Thank you all so much.